Intraprocedural fluoroscopy to determine the extent of the cardiomyotomy during POEM. Hello, my name is Vivek Kumbhari and I'm a therapeutic endoscopist at Johns Hopkins Medical Institutions in Baltimore, USA. Per-oral endoscopic myotomy, or POEM, is a minimally invasive endoscopic procedure intended for the long-term recovery of symptoms of esophageal achalasia. As the primary cause of achalasia is unknown, all treatment options are palliative and directed at decreasing the resting pressure at the lower esophageal sphincter, otherwise known as the LES, and this is to facilitate the passage of ingested food. The POEM procedure can be divided into 4 consecutive steps: the mucosal incision and entry into the submucosal space, creation of the submucosal tunnel, myotomy, and closure of the mucosal incision. It is the creation of the submucosal tunnel, or the second step, that is the most time-consuming and the step associated with the highest rate of adverse events. Additionally, one must remember that the length of the submucosal tunnel below the LES dictates the extent of the gastric myotomy. An adequate gastric myotomy is considered necessary to eradicate the clasp and sling fibers, which are considered essential to maintain LES continence. In fact, anatomic and physiological studies have shown the importance of an adequate gastric myotomy in patients that have undergone a helimyotomy. Furthermore, when patients are either non-responders or early relapses post-helimyotomy, the gastric side of the LES is generally intact, with improvement made with subsequent extension of the myotomy inferiorly. Therefore, based on the helimyotomy literature, one would presume that a generous gastric myotomy during POEM should be performed. However, this assumption is potentially flawed, as the anatomic changes that occur as a result of POEM are different to that of helimyotomy. Additionally, an anti-reflux procedure is now a standard component of helimyotomy, but this is not the case for POEM. Multiple methods have been used to detect the correct location of the LES during POEM. These methods are subjective and often rely on the experience of the operator. Also, these techniques may not be reliably used for those who are new to performing POEM. Therefore, without an objective, simple, cheap, and accurate method of intraprocedurally studying the length of the gastric myotomy during POEM, the right balance, or the sweet spot, between an adequate myotomy sufficient enough to obliterate the LES, but not too much such that it will precipitate reflux, will not be ascertained. Such knowledge may obviate the need for an anti-reflux procedure to be performed in patients undergoing POEM. This manuscript is the first series to describe an objective, measurable method using intraprocedural fluoroscopy to accurately determine and photo document the extent of the submucosal tunnel and subsequent myotomy below the esophagogastric junction during POEM. The esophagogastric junction, seen endoscopically, is the most accurate estimate as to the location of the lower esophageal sphincter. The principle behind our technique is to use a radiopaque object to mark the esophagogastric junction. Then, the endoscope is inserted into the terminal aspect of the tunnel. The distance between the radiopaque marker and the endoscope tip can then be calculated using the known diameter of the endoscope as a scale. This manuscript describes 2 methods of marking the esophagogastric junction fluoroscopically. One method marked the esophagogastric junction with an endoscopic clip placed on the opposite wall of the tunnel, and the other method by placing a 19-gauge needle on the skin at the level of the esophagogastric junction. It was not our intention of our study to compare the 2 methods, though we believe that the 19-gauge needle is superior as it endures less costs and consumes less time. In fact, performing intraprocedural fluoroscopy added only an average of 2 minutes to the total procedure time. The reason for the transition from using an endoscopic clip was that in one patient the clip caused indentation of the mucosal flap of the submucosal tunnel and made the myotomy challenging. However, the clip was simply removed and the procedure continued, but this prompted us to devise the 19-gauge needle method. We believe that the use of our method will significantly benefit those learning POEM and provide them with an element of certainty that they will have performed an adequate myotomy. It may also prevent an unnecessary long gastric myotomy, which increases the risk of bleeding due to large gastric vessels, and also the risk of clinically significant pneumoperitoneum. In addition, one of the biggest criticisms of upcoming studies assessing the rates of physiologic response, clinical response, and rates of reflux during POEM is that the measurement of the gastric myotomy was performed subjectively. This is particularly problematic in multi-center studies where various operators have been involved. This is in contrast to helimyotomy studies where the open jaws of the laparoscopic grasper are often used intraprocedurally to objectively document the extent of the gastric myotomy. Therefore, a standardized method to accurately record the extent of the gastric myotomy will be of significant benefit. Other future directions for the use of intraprocedural fluoroscopy may be to use it to orientate the operator such that the myotomy is performed to the left side of the cardia where the sling fiber bundle is narrower. Additionally, by keeping the fluoroscopic marker at the esophagogastric junction, one can assess the change in characteristics of the LES per centimeter of myotomy, using such tools as the endoluminal functional lumen imaging probe, otherwise known as EndoFlip. This may allow the POEM operator to tailor the length of the gastric myotomy to the individual, which may result in better patient outcomes. We thank you for reading our manuscript.